you very much. And I am delighted to have been able to listen to the prior talks because I have learned a lot already. Today, we're going to talk about the detection of inner and external ear malformations. And the reason I'm including the external is it's something that we kind of ignore. So, who do I want to thank? Well, the pediatric neuroradiologists that I work with, the otolaryngology head and neck surgeons, and the teams that send us these patients, including the geneticists, our MRI technicians and fellows. I mean, we couldn't do this without either of them, especially our MRI technologists who work very hard to get us perfect orthogonal views, and then the departments of neuropathology and obstetrics at Sinai and University of Toronto. And thank you for inviting me to share cases with you. Now, the learning objectives are going to be fairly simple. We want to be able to identify the normal ear structures between 16 and 41 weeks gestational age, and to remember that all but the pinna are silent structures on fetal ultrasound. So I promise you, the majority of the cases that I'm going to show you were sent for non-ear findings. There are the occasional microtias that were sent to us for that, but for the most part, they were sent for CNS abnormalities. I'm going to illustrate the ear malformations in syndromic and non-syndromic patients, not all of them, but there will be some of these will be shown. There isn't time to show all of the different syndromes that are available. And we're going to look at some of the extra labyrinthine structures to aid in phenotype genotype correlations. And those would be the brain and brainstem. And thank you for the prior talk, because now you understand what we're looking for, the calvarium and the extremities. Now, for example, if you're thinking about charge, think about the small pons, the ocular coloboma, the choanal atresia, and the absent olfactory bulbs. And then you are going to look for semicircular canal atresia. And that's going to be the diagnosis that actually makes the diagnosis. If you're going to look at the pons again, let's talk about the dysplastic posterior pontine cap and the absent IAC and pontotegmental cap dysplasia. Important because it's hard to really determine whether the IACs are going to be present in that particular disorder, but I promise you the nerves won't work. And then finally, in Apert syndrome, well, they have lateral semicircular canal analog, which is absent bone islands, and syndactyly, and cruzon, the other one that's going to be the differentiation of the bicoronal synostosis, they do not. So let's start with the external ear. It develops around the first branchial cleft. At 4 weeks, there's the descent of the EAC. By week 6, the hillocks are going to develop, and you can actually see those hillocks, look at the numbering, and then see how that shows up later on by 24 weeks. By week 8, the auricle and the deep meatus is present. By week 20, there's resorption of the meatal plug, and by week 28, the EAC is patent. However, before that, we're going to see the EAC because the meatal plug may actually be bright like the fluid that's filling those structures. Now, we rarely image before 18 weeks gestational age, and by 18 weeks, your pinna should be symmetrical and C-shaped on axial and coronal images. By 25 weeks, you will have developed the normal S-shaped configuration on axial or coronal. I'm showing you the top images because that first image is 57 days, is I think going to be about 8 weeks. And you actually do see the pinna, but we do not actually image that early. Let's take a look at the top view. This was a case of twin transfusion syndrome, obviously not looking for the pinna. But if you're taking a look at the axial view, you can see that little stub, and those are normal. You can see the external auditory canal. You can see actually the tympanic recess here as well, and there is the pinna. And it is formed, but it's not well defined simply because of resolution. By 23 weeks of age, you're starting to get more of definition of the pinna. Take a look here. You're actually seeing some of tympanic recess going out into the basically eustachian tube, and here a pretty nicely developed pinna again. Remember, you always have to get perfectly orthogonal views because you're looking for symmetry. Here by 25 weeks of age, and we image this view just because of prominent pericerebral fluids, that's a nice S-shaped pinna there. You're seeing the indentation of the external auditory canal. You're seeing that as well. And on the coronal view, you can see the coil of the cochlea. Beautiful pinna here. Again, compare side to side. Now let's pay attention to the pinna shape. So here is a 31-weeker, and you can see on your images that you've got very cup-shaped, very stick-out pinna. And you can see that on 2 different views. And yes, there are abnormalities with cyst formation in the brain and prominent pericerebral fluid spaces. This particular fetus had Emmanuel syndrome. There are many other examples of cup-like ears, which could be simplified or protruding, and the common ones would be trisomy, charge. The rare ones would be Emmanuel like this, lacrimo-auricular defect dental, and other syndromic cases. Now, it may just be that it's a normal variant, but they still will require otoplasty in some cases. Here's a 3D fetal MRI, and that's a skin surface reconstruction performed from a FISP sequence that's very heavily T2 weighted. When you look at the source images for that, they're kind of ugly and you can't read much, but you need something heavily T2 weighted so you can identify and separate the skin actually from the amniotic fluid. It's better done on the 1.5 than 3T. We haven't been so successful on our 3T images, although most of our sequences, most of our fetuses are now performed on the 3T. Now here is something just to look at location. I'm showing you images that are a bit grainy because I want you to see that not every image is going to be perfect like the ones we usually show you by choice. So this happens to be a very grainy image that could be due to fetal habitus or maternal habitus. And sometimes we just don't get perfect images. This was done on the 1.5. That's why we can actually do the 3T or the 3D, and you can see here that the pinna is low set. There was micronathia, but there certainly wasn't treacher collins in this particular one. They were symmetrical. You can see them here. They're sort of stuck over a little bit lower than they should be. And when you're taking a look at the actual internal structures, you can see semicircular canals, modiolus, and the cochlea. There happens to be your tympanic recess heading towards your nasopharynx, and so that's going to be the eustachian tube. Now let's take a look at fetal size or pinna size. That's really best evaluated by fetal sonography, and so hopefully your OB and MFM people who are performing these are actually doing the measurement. So this has all been worked out. This has been published back in 2014, and you can see there's a fairly wide range, although the range does change with age. The LMP is down here at the bottom. So here is a 35-week gestational fetus who happens to have prominent pericerebral fluid spaces, big head, and they do have very large ears, so they have macrotia. So again, would this be something we would measure? Probably not, because we're not as accurate. Ultrasound is a little bit better than that. So measurements are less accurate by MRI than an ultrasound, so pay attention to symmetry. Make sure that you have perfect orthogonal views. So here are some syndromes with large pinna. Various overgrowth syndromes and tissue dysplasias. Fragile X is interesting because that is one that's fairly common, although we don't tend to image them as fetuses because we just don't know. And then there are several others that are in that particular list. So anyone that has overgrowth, either hemi or full body. So take a look at the top view, and you can see that this is a case who has hemimegalencephaly. And you can see the cortical dysplasia on the overgrown hemisphere. You can see that there's abnormalities, again, overgrowth of the basal ganglia structures. And when you take a look on the coronal and axial views, one ear is bigger. And take a look on the sagittal views, simplified looking normal on one side and too well developed on the contralateral side. So this was a 22-weeker, and you really shouldn't be seeing that well of a defined pinna at this particular age. I do want you to look at a few other structures on this. So, and you're taking a look at this, you can see here is the cochlea, nicely coiled. Here are the ossicles. You should be able to see those. Here is the actual tympanic recess. And if you were looking at a ventral view of that, you would see that that is going to be extending into the eustachian tube. Again, orthogonal views are crucial because you need to make sure that you have a view that isn't just faking the hemimegalencephaly. So microtia is fairly common and anotia is very rare. They may be isolated or syndromic. So let's take a look at where your pinna should be. Here you can see on this is a postnatal, obviously, structure, and you've got a slight normal posterior tilt of that pinna. Here are various types of microtia, and there are so many different grading systems. Just use the one your surgeons use. Here's a 7-day-old who had anotia due to fetal retinoic acid exposure here. And you can see that there should be an ear there. There's just a little bit of a dimple. And the nose was present. That's just cut off on the reconstruction. Now, always look for the second finding when you find an ear anomaly. And whenever you find a brain anomaly, look for the second finding with regards to ENT. So here's a 26-week set of twins. And you can see that they were sent not to us for microtia, but you can see that they have asymmetry in their head size. The smaller twin has the microtia, and that also has microcephaly. And if you take a look here, There is the pinna on the larger twin and the microtic ear on the smaller twin. So again, this is a 3D reconstruction done on the 1.5. And again, a bit of body habitus and signal to noise problems with this particular sequence, but the 3D was much easier to define. It helped to sort of unwrap all the limbs as well. Now let's move inwards, and this is something that we don't really think about. So we're going to talk a little bit about the tympanic ring and the external auditory meatus. So tympanic rings and EACs or EAMs are horizontal in the fetus and the newborn, and they become more vertical with the skull base growth. So taking a look at that tympanic ring, that's quite, in this 20-week-old, quite horizontal, and will eventually straighten up with skull base expansion and growth. Here's what this would look like on a 25-weeker, and you can see here is going to be the cochlear coil, ossicles, pinna, slightly asymmetric view, but they were okay actually. And here's going to be the tympanic recess, and this is where your tympanic ring is going to be lying. Let's take a look at this 3D again from a 20-week fetus, and you can see here is the, and there's specimen views, by the way. There's your tympanic ring. Here's your tympanic ring extending out. That's where you'd like it to be. And here they are on the axial view, and you can see, again, quite horizontal. So the first pharyngeal cleft is going to give rise to that EAM, and the first pouch to the tympanic cavity and the eustachian tube. And again, these are present on everyone, so you should be able to see the external auditory meatus, again, probably 24, 25 weeks. Here it's not fluid filled. And it's difficult to see at 23 weeks, but you can see the indentation here. You can see the pinna as they should be. They're symmetrical. The ocular structures are symmetrical with the lenses, so you know this is a good orthogonal view. And here, when you take a look, there's going to be tympanic recess, and there is going to be extending medially your eustachian tube. Here in an older fetus, much older, you can see the continuity of that S-shaped structure, which is going to be your external auditory meatus, and you see the eustachian tube aiming towards the midline. Let's keep going, and here happens to be more views from that single 35-weeker, and you can see here external auditory canal extending into the tympanic recess, and here again the ossicles, and there your EAM. Now I want you to know that because this is a very S-shaped curved structure, you might not see it completely on all of your views. So it's lucky that we caught it on the coronal. On the axial view, you can see how S-shaped that is. So always confirm it by going through sequential sagittal views. So again, you can see it very nicely here, and you should be able to roll through that particular sequence and follow it all the way in. Now, the eustachian tubes, also known as the auditory tubes, connect to the tympanic cavity from the connect to the nasopharynx. And let's look at the axial view. It pulled up the 22-weeker sagittal just so you can see that. It's a little hard to define until you start actually searching for these. And I'm not going to tell you much about the brain because, frankly, you've already had a lovely talk on that. But again, this infant was not sent to us to evaluate the inner ear structures or the external ear structures. So again, you can see that you've got your ossicles here, and you have your continuity. Taking a look on your axial views, here's a 25-weeker and a 35-weeker. Here is the actual eustachian tube extending into the nasopharynx. Here happens to be, as far as you're going to be able to see on this one, the external auditory canal. Remember that it's curved shaped. You're not going to always get it on the same view. Here's a tympanic recess. You see it a little bit differently on this particular 35-weeker. Again, your S-shaped EAM. There is your eustachian tube extending inward. And again, your S-shaped pinna, not so S-shaped yet at that particular time, but very well developed on your 35-weeker. Now, the ossicles, the malleus and incus, are going to be visible, but the joint never is visible. So your ossicles tend to look like a lump, and the stapes is almost never identified. So here's a 25-weeker, and you can see on the axial view and on the coronal view, ossicles looking basically like the ice cream cone fused together. They are normal. You don't see the actual mallear joint just because you never really will, even in the older fetus. Taking a look here, you can see the tympanic cavity quite nicely. I want to start pointing out a few other things to you. Take a look here for your semicircular canals, your vestibule. That is going to be your modiolus. That's an important structure. We'll be talking about that later, and you can see the coils of the cochlea on your axial views. I don't have quite the same slice to look at the cochlea on your coronal view, but you can certainly see external auditory canal, tympanic recess, and your ossicles. And this fetus was being imaged for some prominent pericerebral fluids. So let's go and see that tympanic ring again. So here's an 18-week fetal specimen, and you can see on the sagittal view, there's your tympanic ring on one side. Here it is on the other. There's some vertebral anomalies as well. Don't see it on one side. And here you can see it on the axial view on one side, but not on the other. Here's another fetus. This one is now 25 plus 3. They happen to have Goldenhar syndrome, so OAV, microtia, and an absent right external auditory meatus in a station tube. So let's look at the axial view. And again, there is the pinna displaced forward, and it's a bit of a lump. Here happens to be the pinna on the other side, and that's normal. You do have a prominent cisterna magna. Here is the semicircular canals here and here, cochlea. And if you look on this side, you can see the tympanic recess and extension into the eustachian tube. On the coronal view, you can see actually the ossicles. And again, not terribly clear. This is a 25-weeker on an older scanner. And you can certainly see that you have asymmetry side to side. Pinna here is forward, so it's not on that image. And you don't have your tympanic recess. So again, this was Goldenhar. So let's look at what we do after that. So if they actually make it to term, we always do postnatal 3D CT reconstructions for the surgeons. And you can see in this particular fetus who has Goldenhar syndrome that you have zygomatic and TMJ deficiency. I don't really see a fovea for that coronoid process here. You've got an overgrowth of the coronoid process, that would be your condylar process, I mean, and you certainly don't see a good TMJ. Here is the microtic ear, and on the other side, a normal ear on your newborn MRI. Take a look here, and you can see fatty tissue. So this microtic ear is going to have a combination of sometimes bony and sometimes fatty tissue, sometimes just very abnormal mesenchymal tissue. And that's what that would look like on MRI. Now, beware of positioning. So I've already showed you what the pinna should look like. So I'm going to show you two different sequences in the same fetus. We were following them up for brain. Here at 26 weeks, you can see that the hand on this particular image was pulling on that pinna, but the pinna looks normal. Here's the EAC. You can see a bit of the semicircular canals. There's your cochlear base. Your basal turn. Here is your eustachian tube going to the midline. Here is your tympanic recess. And you have certainly some abnormalities in terms of your cisterna magna. So there again, take a look at this one, see what this hand has been doing, and that hand tended to stay there all the time. So that was at 26 weeks and a normal ultrasound with regards to the pinna. Take a look here, and the fetus now at 28 weeks has moved that hand away. And that pinna is overlying, it sort of folded itself over. Well, how do we know to look again? Well, let's take a look at that tympanic ring and those structures. So not even going back to this one, but looking at this one, yes, you've got a normal pinna on one side, a folded over one on the other side. When you're taking a look at your cochlea, there you are here, ossicles, tympanic recess, and your structures of your middle and your inner ear are normal. And also, when we called and said there was a possible microtia, our ultrasonographer said to look again because they didn't see that particular inches. Yes, there are abnormalities of the brain as well as prominent pericerebral fluid spaces. And I believe that that particular fetus had CMV. So let's go onward to labyrinthine development. This just shows that there's a reproducible pathway of inner ear formation from the stage of ectodermal surface thickening here to completed labyrinthine formation down here. So initially you go through the thickening, the otic pit, the otic vessel being pinched off here and here, and finally you get budding of your cochlea and your vestibular buds right here. And then eventually you're going to have the cells leaving the otic epithelium to form the neurons of the statoacoustic ganglion. And here basically are your hair cells. These are all from the website of Dr. Mark Hill from this particular website. And he says that go ahead and use those images, feel free, as long as they're actually going to reference his particular website. Now, there are a large number and variety of genetic molecules, whoops, I'm missing a C there, regulating each step of photosystem induction and patterning, and they include transcription factors, motor molecules, extracellular matrix components, cytoskeletal proteins, and gap junction components. Let's just start and take a quick look through these. Here, the otic plaque code will form from ectodermal thickening, the periotic mesenchyme and neural crest cells form between the surface ectoderm and the hindbrain. The otic plaque code is going to invaginate to form the otic pit. Here you can see the otic vesicle has pinched off, and here you've got neuroblasts that are giving rise to those statoacoustic ganglion regions and delaminating from the anteroventral cyst. And then you've got the endolymphatic and cochlear poles forming ducts. Okay, and eventually you'll have periotic mesenchyme condensing around the inner ear to form the bony labyrinth. At this particular stage, we can actually see the structures because there's a really nice demarcation between the fluid and the cartilage and bone on imaging. So any one of these stages can have a genetic mutation or a toxic insult, and you're going to actually affect the timing or the location or the function of these proteins, and they lead to predictable and recognizable malformations. We're not going to show Michel's labyrinthine aplasia, which would be an arrest at this particular stage, because it just shows no inner ear on your imaging. So make sure you look and count how many inner ears you have. There should be a right and a left, and if you're missing one, you ought to be thinking about a Michel's. Microvesicle means you've pinched off one of these little cysts and you haven't really gone on to form anything else. When you get to these next stages, you're starting to have common cavity and IP1s. These are pretty easily identifiable in fetal MRI. These particular 3-4 images are done on a CT reconstruction, and this particular one is a fetal MRI petri dish of a normal particular specimen. Now let's start with common cavity because that's where we're going to start. And they were actually described, both of these structures, back in 1838 by Edward Cook. He basically talks about the fact that the auditory canal opens into a cavity, and that particular cavity is not separated. So you've got a continuous cavity between the cochlea and the vestibule. And interestingly enough, there are nerves. And the reason that's important is just because we diagnose a common cavity or an IP1 does not mean that that particular fetus after birth is not going to be able to hear or to at least go for a cochlear implant. So despite the appearance here, there will be nerves expanded on that particular specimen. Now, here's incomplete partition type 1, and this particular fetus was sent for callosal dysgenesis and cortical dysplasia. Taking a look here, you can see a very nice palate, and so your face is also normal. Taking a look at the inner ears, I'm not showing you very pretty views of the pinna. They were okay on other sequences, but you can see here you have a very bulbous cochlear bud, and it's lacking the modiolus here in the coronal views. Again, you have a little asymmetry in size, but you have no modiolus. There you do have your ossicles here, and your tympanic cavity and recess. Yes, of course, there is a diffuse cortical dysplasia in this particular fetus. Now let's take a look at the modiolus. It is an early marker of a normal cochlea, and it's present even here on 19 weeks. So taking a look, that black dot is going to be your modiolus. There's your cochlea, a cochlea again, semicircular canals, and your vestibule. There's a little pinna here. This one's a bit obscured by the overlying placenta. Here at 21.5, you've got modiolus, semicircular canals, and vestibule, pinna, a little indent where the EAC is going to show up. Here at 24+4, these are the same particular fetus. You can see you've got modiolus, semicircular canals. If you don't see the entire ring of the semicircular canal, but you see a V shape, that's still probably going to be normal. Here is your coronal view of your actual cochlea. That's going to be the modiolus here and here. Again, ossicles. Here is going to be your tympanic cavity and extending out into where you're ventrally going to have the eustachian tube. Here's one that's not normal. So take a look at this coronal. There's a wide space between the coils. Take a look at your axial views. Here you can see a modiolus sort of centered in a little cap. There it kind of looks like a bit of a coffee bean. So you've got a stripe there. That is not a normal modiolus in this particular fetus. Had other anomalies as well, had CDK 20 mutation. So let's take a look now at semicircular canals. We know that at 4 weeks of gestation, you're going to have a vestibular pouch enlarging to form the basis of the 3 semicircular canals, and the medial walls will resorb to form the anterior, posterior, and horizontal canals. Horizontal is last, and therefore most likely to be abnormally formed. So taking a look here and comparing to this, and this is basically taking a look at a fetal inner ear, and that's by a beautiful article by Johnson. You should take a look at that because the pictures are stunning. So again, always take a look. You should be able to count 3 hoops. So here is a normal semicircular canal. Here lower, there's the basal turn. You can see a horizontal here and here. Taking a look here, you can see semicircular canals. That's the axial view. There's your modiolus as well. And here is your tympanic cavity with your ossicles. Taking a look here, that's a coronal view showing that you have nice semicircular canals. Again, brain very abnormal, and that's why we were imaging. Well, let's take a look here. When do we have problems? Well, you can have hypoplastic semicircular canals, small bone islands. This structure here, that's the bone island. It basically is an island in the bone of, this is going to be the semicircular canals. That's the vestibule. It's too small. Well, who gets small ones? Well, aneuploidy, trisomies, velocardiofacial. It's usually the lateral semicircular canal. It is the last to form. The actual vestibule may be or just look large. And if you happen to have posterior involvement, consider Alagille or Wardenberg. Here happens to be a fetal 3D reconstruction showing lateral semicircular canal and bone island hypoplasia. So here's a normal loop, another normal loop, very small and a very abnormal cochlea as well. It's a bit thin and it doesn't have the complete number of coils. Here happens to be modiolus and modiolus. These are not the same fetuses. Let's take a look now at persistent onlog, which is failure of apposition and resorption is going to lead to a primitive onlog of the superior semicircular canal. That just means primitive. So here you have a bone island. Here you don't have a bone island. You also have a midnasal cavity stenosis. There's your pinna, there's your pinna. We have a little problem on this particular sequence with some artifact. But then when you come out here, you can see the abnormal temporal lobes that you saw nicely on the prior talk with Ajay. And that's an Apert's case. Here is a terminal density and the abnormal bicoronal synostosis, the flattening of the face. And taking a look here, those are fused digits. So this was Apert's, and that was confirmed. Taking a look at this particular study, you can see there's an onlog on one side, not on the other. Those are actually ossicles and ossicles. It's a 1.5 sequence confirmed on a postnatal NICU. Here's a 3D fetal MRI showing that there was a central polydactyly with a cleft foot, and this particular fetus did have a confirmed diagnosis. So here, let's take a look at absence of the semicircular canals. Semicircular canal agenesis is the most easily recognizable charged inner ear anomaly, and it sorts with CHD7 mutations. In fact, you could say if you see it, you're very likely going to have CHD mutations, even if you don't have some of the other features. So let's look at those. Bit of a short pons here. So the height is just a little too small. They often have a big cisterna magna, sometimes a rotation of the vermis, although it is formed if small. You don't have olfactory bulbs here and here. There is your actual choanal atresia. Your pinna aren't particularly cup-shaped on this particular study. They may be, and you don't have semicircular canals, no matter how hard we tried to look. Now, you can also have segmental hypoplasia of labyrinthine structures. Remember, why do we have these in association with brain anomalies? Well, because of long-range sonic hedgehog signaling. So just remember, ventral induction is a problem, and it certainly does go along with some of the inner ear anomalies that we see. So here's normal. Here's one that has one mutation. Here's one with another, and you can see no cochlear bud here, and frankly, that's just a bit of a blob or a common cavity. So let's take a look at this particular fetus, and we've seen one of these before. So here is the Z-shaped or S-shaped brainstem, also ventriculomegaly. There is a hypoplastic cochlea. here and here. If you take a look here, you can see a bit of a cleft brainstem here, hypoplastic cochlea here, and here is the unwound cochlea. And this is a fetal specimen. Basically, this is done in a petri dish, essentially, and that is of the same particular fetus. So again, if you see this particular finding, take a look at those cochlea because you may find that that is a helpful clue in confirming a dystroglycanopathy. Now, take a look at the brainstem as well. So we should always be looking at the brainstem. This particular one fetus was sent to us for an ultrasound showing a small round cerebellum. What we found was a brainstem cap, so a posterior cap, so we know right away that that's going to be pontine tegmental cap dysplasia, which is a disorder of impaired axonal navigation. They happen to have narrow brainstems and cerebellum, and they're missing nuclei. That's why their brainstem is so narrow. And they have hindbrain malformations that are associated with cranial nerve 5 through 8 deficiencies. So not only are they going to be deaf, but they're actually going to have some areas of facial numbness, and they often end up with self-induced injuries. So taking a look here, this looks like there's a modiolus, and certainly there is. And I told you the modiolus is a marker for normal cochlear development. We never do see anything that looks like a fundus or an internal auditory canal. And again, that's a pretty subtle finding. Here happens to be the Petri dish samples on CT, and you can see that here there are two internal auditory canal foramina. So this was going to be one that's got a split or a duplicated IAC. Here you can see the modiolus is present. You really don't see anything going out that looks like it would support a nerve. And I promise you that even though you do see foramina here for your split nerve, those nerves are not going to be functional. So again, there certainly was a modiolus present on this one, just no IAC, and the brainstem was the clue. So your major take-home points are going to be that MRI gives added value with regards to middle and inner ear structures. And remember, a lot of those were silent on ultrasound. It can also identify specific labyrinthine abnormalities, aiding in phenotype-genotype assessment. So really do sweat the small stuff. Get true orthogonal planes, look for the modiolus, and don't forget the extra labyrinthine and extra CNS structures. And contralaterally, if you have an abnormal brain, make sure you're also looking at the internal and external ear structures. Thank you very much.